Hey guys, in this video we are going to be talking about the pathophys behind secondary hemostasis. First, I want to talk about a disease that I had mentioned when we discussed primary hemostasis that I was going to bring up during secondary hemostasis because it was involved in primary hemostasis as well as secondary hemostasis, and that disease is von Willebrand factor deficiency. So von Willebrand factor deficiency, it is an autosomal dominant disease, and it affects females more than males. Now, keep in mind, we talked about how VWF, it came from endothelial cells, the damaged endothelium, right? It can be produced by endothelial cells as well as megakaryocytes. And when we talked about pathophys of the primary hemostasis, we said that that would involve bleeding into the skin and mucosa. Now, the majority of pathologies in secondary hemostasis will be bleeding into joints and soft tissues. Okay. However, VWF is the exception, and that's why I'm mentioning it first. Now, again, VWF deficiency, autosomal dominant, females more than males, and Caucasians are more likely to have it. With VWF deficiency, this is the patient and clinical vignette. I can't tell you how many times I've seen this. This is the female who starts her menstrual cycle, and it's extremely, extremely heavy. So, heavy menses, epistaxis, so bleeding from the nose, gingival bleeding, again, this is skin and mucosa mainly, petechiae, and easy bruising. Now, something to keep in mind, and this is going to help you so much whenever we think about the lab values that will be off with VWF deficiency. Which pathway did it affect in secondary hemostasis the most? Very good. It affected the intrinsic pathway, which means that we're going to see an increase in PTT. Did it affect the extrinsic pathway? No, it did not, right? So PT will be normal. Now, back over to primary hemostasis. What was the lab value we checked during primary hemostasis? Bleeding time, right? So for all of our pathologies with primary hemostasis, bleeding time was affected. This is no different. So VWF is the pathology in which we're going to see an increase in PTT as well as an increase in bleeding time. The rest of the pathologies that we're going to discuss in secondary hemostasis do not affect bleeding time. And that is why I wanted to bring up VWF deficiency first, because it is the exception. It affects the intrinsic pathway, and so it's going to increase PTT, and it also affects primary hemostasis as it is released from those endothelial cells as well as megakaryocytes, so it will cause an increase in bleeding time. Now, keep in mind, the way that we are going to diagnose VWF deficiency is through a Ristocetin cofactor assay. And we will see a decrease in platelet agglutination. And the way that the vignette will phrase it is, it fails to agglutinate on ristocetin. To treat it, avoid aspirin. DD-AVP or desmopressin can also help with VWF deficiency as a treatment. So this is more prevention, and this is treatment, because DD-AVP can increase the release of VWF from endothelial cells. And then if the disease is refractory to DDAVP, we can do factor 8 replacement because the factor 8 replacement contains VWF. Cryoprecipitate is no longer used, so do not click that on your test or on your practice test. Okay, that's VWF deficiency. I'm actually going to scooch this right over here so we have plenty of room for our pathologies that are strictly in the Clotting Cascade. Now, we can have a deficiency of factors in the intrinsic pathway. So what if we have a deficiency of factor 8? Well, a deficiency of factor 8 is called hemophilia A. We can also have a deficiency of factor 9A. And that is called hemophilia B. Now, I'm grouping these together because clinically, it's very difficult to tell them apart, okay? They are almost indistinguishable clinically. They are both inherited. X-linked recessive, which means that, if you recall from genetics, they will be almost exclusively found in males because in recessive diseases, whether it be autosomal recessive or X-linked recessive, in order to express the disease, a patient must have both alleles affected, right? However, males only have one X. So males will express the disease no matter what if they have one X that is mutated. Now, again, we talked about secondary hemostasis. They're going to have bleeding into joints and soft tissues. Okay, this is no exception, okay? They are going to have spontaneous bleeding following trauma or surgery, easy bruising, swollen or painful joints. And again, this is generally from the time of birth, okay? Now, here's the cool part. Our lab value, what is going to be increased in both hemophilia A and in hemophilia B? Good job, right? PTT is going to be increased because it affects the intrinsic pathway. So we're going to see an increase in PTT, and PT will be normal. And bleeding time, because this again does not affect primary hemostasis, bleeding time is going to be normal. Now, the most specific test, so this is a way to screen for it, is do they have an increase in PTT, normal PT, normal bleeding time? Do they clinically fit? So do they have bleeding into their joints, soft tissues, swollen, painful joints? Again, is it a male because it's almost exclusively in males? Okay. The most specific test is called a functional assay for factor 8 or factor 9. Depending upon which one you're testing for. Now, again, treatment here for mild cases, okay, is going to be DDAVP for hemophilia A. Again, when we were talking about DDAVP for VWF deficiency, we said that DDAVP increases endogenous factor VIII. And with hemophilia A being a factor VIII deficiency, that would seem quite useful. Now, in severe cases, we will have to do factor VIII or factor IX replacement. Okay, now, what if we have a deficiency of factor XI? This is a new one that has been showing up on practice questions, and it is pretty much clinically indistinguishable from hemophilia A and B, except for it is hemophilia C, and it is inherited autosomal recessive. In other words, males are not going to be predominantly affected. It will affect males and females equally. All right, now let's get into our next pathology, which is going to be a vitamin K deficiency. You recall that vitamin K is given to all newborns, right? There are 3 things given to all newborns. All newborns get vitamin K, erythromycin eye drops, as well as Hep B vaccine, right? Now, why do all newborns get vitamin K? Because they have very immature gut bacteria. And because they have immature gut bacteria, they cannot produce vitamin K, because vitamin K is produced in the gut by bacteria. And neonates don't have mature microbiome. So what does vitamin K do anyway? Well, vitamin K has several clotting factors that it stimulates and that are dependent upon it. And those factors are factors 2, 7, 9, 10, protein C, and protein S. Now recall from our physio video, what did protein C do? It inhibited factor 5, right? Factor 5 is prothrombotic. So actually protein C is, in a way, antithrombotic. It inhibits factor 5 from stimulating the common pathway. It also inhibits factor 8 from stimulating the common pathway. So protein C and S are a way of checks and balances of preventing clots. It's a way to keep this clotting cascade from getting away from itself and just making a bunch of clots all of the time, right? Now, again, vitamin K deficiency occurs in all neonates. That's why we give it to them, but it can also present due to malabsorption, as well as long-term antibiotic therapy. There are certain antibiotics, some cephalosporins to be specific, that can cause vitamin K deficiency. Now, symptoms here are no different. This affects the clotting cascade. So we're going to see bleeding into joints and soft tissues. Okay, now, what are our lab values going to be? Well, it affects factors 2, 7, 9, 10, protein C, and protein S. So we are going to see an increase in PTT and an increase in PT. Bleeding time will be normal. Awesome. Now let's get into our next pathology, which is going to be a protein C and or protein S deficiency. I like to put protein C, protein S, and factor V latent mutation together because they are very close in the way that they operate. So protein C deficiency, protein S deficiency, and factor V latent. Now, all of these other deficiencies are going to cause more bleeding. All of the ones that we've talked about so far are going to cause more bleeding. The next that we're talking about are actually going to cause more clots. How so? Well, again, we talked about protein C inhibits factor V. Factor V wants to make clots. It wants to stimulate the common pathway to make clots. So if protein C is deficient, it cannot inhibit factor V. So what are we going to get? More clots. Exactly. Same thing here, right? It's not going to be able to inhibit factor VIII. Factor VIII is then going to stimulate the common pathway as well, and we're going to get more clots. Now, the problem with factor V latent mutation is that we have protein C, we have factor V, but the binding site for protein C on factor V and on factor VIII is mutated. Specifically here it would be factor V because it's factor V latent mutation. So this binding site is defective. And so as a result of that, protein C cannot inhibit factor V. Here we have a deficiency. And the same thing applies here. Now, protein C and protein S deficiencies are inherited autosomal dominant. And our factor V latent mutation is also inherited autosomal dominant. So how would we be able to tell the difference? I mean, all of them cause recurrent DVT, increased risk of spontaneous abortion, right? And as a result, think of like PE as a result of the recurrent DVTs, any thrombosis, right? Hepatic vein thrombosis, central retinal vein thrombosis, and also our PT and our PTT are going to be normal because it's not increasing either one of those because these are not diseases of bleeding, right? These are diseases of clotting. So they'll actually be within normal range. The way to distinguish the difference between them is with factor V latent mutation, we would see an increase in protein C because protein C will increase in order to compensate. It's saying, I really want to bind, but I cannot bind because there is no binding site for me, so I can't inhibit, right? So again, it's a problem with the binding site. Protein C will be increased, factor V will be normal, but there will not be any checks and balances, and they will have these recurrent DVTs, PEs. With protein C deficiency, we would actually see a decrease in protein C, and factor V is going to be normal, right? But it's actually the enzyme deficiency, and the same thing applies with the protein S deficiency. Now, the treatment for each of these is a bit different. For protein C and protein S, we can give them the specific enzyme. Okay, and we can anticoagulate them with heparin. Patients taking warfarin that have a protein C deficiency, and we'll get to this in our farm video, they end up having hepatic skin necrosis. So that's also a clue for a protein C deficiency. A patient just started warfarin, and now they have this necrotic skin over their liver. okay? And we'll get to that whenever we talk about the farm. With factor V latent mutation, the way that we would treat that would be with low molecular weight heparin. This is a little messy, sorry guys. And we could bridge to warfarin with the factor V latent mutation, okay? Now, in any of these diseases with hypercoagulability, we want to avoid OCPs. So make sure we avoid OCPs, avoid estrogen, exogenous estrogen, okay, or anything that increases the risk of a clot. Now, antithrombin 3 deficiency, okay, antithrombin 3 deficiency, it also causes more clots. And I'm going to draw this one down here. Again, sorry guys, I know it's messy. Antithrombin 3 deficiency. Antithrombin 3 inhibits thrombin and inhibits 10A, right? So it actually inhibits the common pathway. And so what are we going to get if we inhibit the inhibitor? Well, we're going to get more clots, right? So they're going to be hypercoagulable. This is also inherited, autosomal dominant. Okay, they are going to have liver disease, could be a risk factor, nephrotic syndrome, and heparin use could also be risk factors for the antithrombin 3 deficiency. They're going to have DVTs and PEs as well. And the way that we would treat this is with heparin to prevent the clots, as well as antithrombin replacement therapy. So this pretty much sums up our pathologies involved in our clotting cascade. I hope this video was helpful. If it was, like it, give it a thumbs up, and subscribe. Thanks.